Good afternoon. And now that we are all expert in all the pathology and we know how the valve look like, so how do we do? What do we do when we need to diagnose someone? So obviously we don't open the chest and take a look at those pictures what Dr. Wynn showed you. So we are trying to get as much information as possible from our other imaging what's available nowadays. And I can tell you, since I started echocardiography and started my career as a cardiologist, those image availability and the technology is just amazing, truly amazing in the last 30, 40 years. So let's see that we can go to the next slide. On this slide, we are going to peek inside of the body. And what you can see here is what you've seen before. This is the aortic valve, and this is opening, closing the 3 leaflets, and this is a 3-dimensional view. And before I continue, I'd like to say that I don't have any disclosures, but I'd like to thank our team and also Zach Ketchum, who helped to put together these images, which are all our own images from our lab. So the aortic pathology is a very complex anatomy, as you could see, and understand requires multiple imaging to really know what we are looking at. This is how we diagnose, this is how we monitor, and also we use it during the treatment. Those TAVR procedures never happen without echocardiography. So the aortic disease can be associated with significant morbidity and mortality, as we all know. The clinical presentations can be very non-specific. Sometimes people just don't know that they have any problems. And the very common scenario in our echo lab, and our techs who are sitting there know this very well, that someone shows up with having a little bit of shortness of breath, and we find something that's really significant. And these are the incidental findings. We'll discuss here the strength and limitations, as well as the common preferred use of the different imaging. And by the end of this, we'll be all expert on these. So what imaging available for us? The oldest imaging is like the chest X-ray. Most people already had a chest X-ray in their life. And also that some of the people will have also an EKG. This still has a role, and an important role, but also the problem with this imaging that they lead to incidental findings. The transthoracic echocardiogram is one of the everyday imaging what we do. And then there is a more specified transesophageal echocardiogram. We also use CT scans, which are different types available, and with and without the contrast material. We have MRI now, which is the magnetic resonance imaging with or without the gadolinium contrast use. We have combined techniques. We actually, one of the most sophisticated things now, when in the cath lab where we do this TAVR, we can actually have multiple imaging, and they superimpose themselves, helping the operator to guide where do they go and how do they go with their procedures. And the invasive imaging, which I'm not going to get into this time. So here is the chest X-ray. This is the oldest imaging methodology. As you know, most people have one more or have more in their lifetime. It's important to visualize the heart, and this is what immediately we'll find. Someone has a pneumonia and the lung infection, and suddenly they find, oh, by the way, I see something else on your heart, or your heart is bigger than it should be. Or maybe in a congenital findings, your heart is not on the right place. It's actually on the right side rather than on the left side. And then we can see the aorta very well, also the mediastinum, but becomes well-known initial recognition sometimes when you have a suspicion for aortic dissection, the widened mediastinum, as in this picture. So then there is the transthoracic echocardiogram. You have back there, you can see that size of that machine. That's the ultrasound imaging with significantly improved image quality since the first machines were available. And it was 1953 in Sweden when they started using it. It was Dr. Adler and then later on a physicist, Hertz. I was lucky enough to be there when one of the first machines were started to use in Europe, not in 1953, but in the 1970s. The non-invasive and no radiation either, and one of the easiest thing to repeat anytime, right? So it's a very easy procedure. Now that it's widely available, really no hospital exists, I think, in the United States where is no ultrasound machine available. But look at this. I can actually now connect the probe, which is on the right side there, to my phone. And I can get at the bedside a really good quality echocardiographic picture rather than using my stethoscope. Nowadays, when I round with the residents, I take my echo machine and my phone with me, and I get the pictures right away. There is no waiting there. So the transaortic echocardiogram is beside the images. It gives very accurate and very important measurements. And these measurements are the ones that we follow and monitor during the years. Each can be obtained, guides us the decision. This is what everybody looks at in the echo report. And these based on physics, which are very useful, and is called it biophysics. So we take measurements. The M mode, which is rarely used nowadays, this is used based on like the old type of oscillogram. I don't know any of you know how the oscillogram works, but this is only one line, one ultrasound line goes across the pictures. It's still very useful for accurate measurements. And there is the two-dimensional echocardiogram, and believe it or not, we have the three-dimensional echo, which I showed you at the beginning. And there is the color Doppler and the Doppler, which based on, again, the Doppler physics, and that's help us to use the measurements and follow-ups and obtain, usually in every single echo study, what we do. In addition now, there are some new terminologies like the strain imaging and the tissue Doppler. They are not used mainly for valvular heart disease, but they're used for left ventricular function evaluation or evaluation of the stiffness of the heart. Now, just a quick picture here just to show you how a 2D echocardiogram actually looks like. We'll talk about it a little bit more in a second. But these are moving pictures, black and white. The black is where the blood is, the white is where the tissue is. And these reverberations and the depth in the body gives us the idea what is where. So we are going to talk about it. Then there is the transesophageal echocardiogram, which is an invasive test. And on the side there, you can see how the probe is going inside of the body. And most of the people, before they have any kind of valvular surgery, they will have a transesophageal echocardiogram. And this is an invasive test because it goes inside of your body. The advantage is incredibly great images. It's just very well visualized. Everything is like holding the heart in your hand. And even the very small abnormalities in a couple of millimeters, we can actually distinguish. Most patients will get sedation, so don't worry that this probe is just going to go down and you are wide awake on it. Sometimes even use anesthesia with it. So it's a pretty comfortable procedure overall. It's used during the cardiac procedures in the catheterization laboratory. We use it in the operating room. Everybody who has cardiac surgery, they will have a transesophageal echocardiogram in the operating room. That guides the surgeons nowadays also. So performed by the cardiologist usually. I start my days usually in the operating room. And then the anesthesiologists in other hospitals or other settings, they are the one who perform these also. The same 2D, three-dimensional Doppler available on the transesophageal echocardiogram, and not uncommon to use also some saline contrast to visualize some communications in the upper chambers. Now here is a very abnormal transesophageal echocardiogram. Everything is upside down now compared to the previous one. I wish I would have a pointer here, but the top, where the P is, that's where the probe is, and the top is a left atrium. The bottom is the left ventricle. There is the mitral valve, which is also not normal in this case. And then there is the aortic valve, which is not opening very well. It's on the right side. So here is another picture, and this whole talk today is going to be a lot of show and tell. We talked to you about what you can find. I really would like to show it to you. So this is what hanging in there on that aortic valve. That's a vegetation. You've seen how it looked like when Dr. Wynn showed it to you on the pathology report. This is how, on the pathology, this is how it looks like in real life. Those little things shouldn't be there. Because this is the other picture of the aortic valve. You can see it, how difficult to open it. It doesn't open like my three-dimensional picture opened before, or the two-dimensional picture. This is aortic stenosis. The hole in the middle is very small. This patient has 3 leaflets, and you can see the calcium build up on those leaflets, especially on the base, and then extending everywhere. So then there is the CT, the computer tomography. And believe it or not, this is actually a CT picture. I choose this because I wanted to show you what we can do nowadays. This is the 3-dimensional view of the CT. And there is, of course, X-ray used. We can do cross-sectional pictures of it, but also we can do this 3D reconstruction, which allows us to see the whole heart, the aorta itself. We can see everything very well. And if I want, I can slice these up also in 3-dimension or 2-dimension. I can take measurements. I can enlarge them. I can turn them around. I can do anything what I want with this picture. There is, of course, the MRI. The MRI pictures are really cool and really good because they are used gadolinium contrast, which doesn't affect as much the kidney as other contrast materials, and no radiation. We use magnetic field and radio wave energy to create these awesome pictures, especially when there is an MRA. We can see very well the whole aorta. So we are allowed to see like that there is a coarctation, or I have a suspicion for a coarctation. I would be able to see that. So this is also very helpful, and in certain cases, especially in congenital heart disease, easy to follow the patients with MRI. So let's go back again. Let's start from the beginning. So aortic valve, normal valve is tricuspid, as we heard. It has 3 leaflets. The sinus of Valsalva, where is marked there, that's a little bulge after the valve. And then there is a little narrowing, that's the sinotubular junction. And after that, there is the ascending aorta. Each of these things on your echocardiogram is measured at the time of the echocardiogram performed. And the most common and congenital abnormality, as we heard, is the bicuspid aortic valve. That only can be seen on this picture. We turn the probe, and this is actually still a 3-leaflet aortic valve. There is everything marked here. The P is the probe up there, and this is a regular transthoracic, not a transesophageal echocardiogram. And these are all the structures, what we see there. So there is the aortic leaflet. That is the sinus of Valsalva, and we look at the size of the sinus of Valsalva because some people can have the congenital abnormality, which is rare, but there exists, the sinus of Valsalva dilation, and that also can rupture not just the ascending aorta. There is the tricuspid valve there, the right atrium, the left atrium. If there is a communication between the left and right atrium, this would be the picture to see, and there is the right ventricular outflow tract. When we go and look at this, here it moves, and you can see that one of the sinus of Valsalva is actually dilated. It just looks bigger than the other. And this is how we look at it. This is one of the pictures. When we get a 2D echocardiogram, we try to slice the heart in different ways, and we put our probe in very specific locations to get the pictures. So the next time someone comes in, they can get the same picture again to be able to compare to the previous one. This is actually a bicuspid aortic valve. This patient does not have the 3 leaflets as the previous patients you've seen. So this is the view when we actually can differentiate the bicuspid and the tricuspid leaflets. Now again, back to our original picture. Again, the aorta is very well seen there. These are very thin leaflets. There is no aortic stenosis, no aortic regurgitation. There's nothing happening with this aortic valve is normal. There is also the mitral valve, which moving, opening, and closing in diastole. The aortic valve is opening in systole, so that's why we actually have an EKG on every single echocardiogram. So that's also help us to guide what are we looking at. Now, the aortic valve diseases, we heard a lot about them already. You know, the aortic valve regurgitation, the aortic stenosis, which is congenital or infection-related. We already saw the vegetations there. The aortic valve infections can result in either the regurgitation, and rarely, but I've seen it for aortic stenosis itself. Maybe a little bit later, someone has like an infective endocarditis, and that's actually prones them to have an aortic stenosis. Rheumatic or different organisms also can do that. Staphylococcus is one of the most common, streptococcus, and so on. The tumors can also grow, unfortunately, on the aortic valve, and that's the most common tumor. What we find is the fibrillostoma. Here is the aortic regurgitation picture. Again, back on the left side, you saw those vegetations which were hanging there. And you can see that will cause severe aortic regurgitation, where the very, very turbulent flow is going back into the left ventricle. As you've seen in Dr. Wynn's talk, you know, this is causing dilation of the left ventricle. This is most likely an acute aortic regurgitation, not well tolerated. This is the patient who is going to go to the operating room the next day or pretty soon after has negative blood cultures, because this valve will need to be replaced. And just for because I get this question a lot, these things, when you have aortic regurgitation, it will be in the future, but right now, these patients cannot have TAVR. So this is a surgical replacement of the aortic valve. And this is, again, a 3-dimensional picture, and this is the aortic stenosis. You can see how it's not able to open as well as you've seen it on the previous ones. If I want, I can stop this and I can measure the aortic valve area, which also gives us an idea about the severity of the aortic stenosis. The normal valve area is 3 or sometimes above, and we know that if it's under 1 centimeter square, those are severe aortic stenosis. Those patients need something to be done. And this is how we measure it. So this patient had a Doppler. This is just pure physics. This is, we measure it when the gradient, that's what we call, but is the velocity difference or the pressure difference between the left ventricle and the aortic valve, and the aorta itself. So we put it there, the cursor, and that's able to measure us what is that gradient. What is the heart has to work against to push that blood out to the aorta. So that velocity here is elevated. This is an aortic stenosis. The patient most likely will need a TAVR or a SAVR. The mean gradient is 38. When it is 40, we call it really severe aortic stenosis. Those patients are going to go to the operating room, and after the TAVR, their gradient is going to be maybe 8 mercury millimeter or 10 mercury millimeter. So that's a significant decrease, as you can tell. We also calculate the aortic valve area. It's again just the pressure in the heart, inside of the heart, and also the difference between the inside and the aorta, and with a mathematical formula, we can calculate the aortic valve area from the pressure difference. Then there is the ascending aorta, which we all heard about today. It can have the dilation, can have an aneurysm. The dilation, we call it up to 4 centimeter, and above 4, 4.5, we call it aneurysm. So not everything is aneurysm and not everything is dilation. So you have to have it dilated to call it an aneurysm, but not every dilation is actually an aneurysm. It can be congenital or age-related. There is a plaque formation in the aorta. We call it like due to atherosclerosis, and we are able to visualize that. I will show it to you. And then we heard about the aortic dissection, a tear of the inner layer of the aorta, which can rupture later on. So we can find the dissection before it ruptures. So that's a very important statement here. And then we have the atheromas, which are plaques or atherosclerosis, and then the intramural hematoma. So believe it or not, this patient came to us as this was an incidental finding. Most likely this patient has Marfan syndrome. As you can tell, the aorta is markedly enlarged. This was an incidental finding. This did not rupture. This is not a dilation, this is an aneurysm, and you can say the whole thing is dilated from the beginning of the valve. And it was measured 6.4 centimeter. You already heard that up to 4 centimeter we would call it normal, and this is 6.4 centimeter, 1.5 times larger than what it should be. Needless to say, 2 days later, this patient was in the operating room and we replaced this aorta. And she is lucky that she did not have any rupture, she did not have any complications, and so forth. Valve not necessarily needed to be replaced. We only replace the valve if there is severe regurgitation there. We have a lot of patients who had aortic aneurysm and aortic aneurysm surgery without replacement of the valve. So this is another unlucky patient, again an incidental finding, showed up in our lab with shortness of breath. And this is a transesophageal echocardiogram because this was done already in the operating room. This patient has the dissection. You can see that the inner layer is lifted up. On the up and the bottom is like having 2 tubes there. And these are the 2 tubes, and you can see that that valve most likely will be replaced because you can see how it's falling back already into the left ventricular outflow tract. This is how it looks like in the aorta further down, just under the arch. So we know that this dissection actually went further, did not stop locally just in the ascending aorta, but continued down into the descending aorta. That little communication is there on the right upper corner. You can see that this is where it started, most likely, and then went up from there. So we can show with our imaging the entrance point, where it starts, and where it finishes. So that really helps the surgeon and guide them where and how to replace that aorta. It's a smaller image, but you can see the atheroma on the left side, the 3-dimensional view of it, those little bumps what coming on the aorta. And on the right side, you also can see this atheroma which should not be there. These are cholesterol or atherosclerotic plaques which build up in the aorta with aging, with high cholesterol, and sometimes it can be even ulcerated or can be between the layers, and that's the intramural hematoma. But this can be visualized nowadays quite well. We did not know about the existence of this until our imaging were as good as it is nowadays. And then finally, I just wanted to show you that the coarctation of the aorta, we also use Doppler with it. There is an image of it, and it's congenital and sometimes discovered as an adult. And this is the measurements what we make. It's very similar to the aortic stenosis measurement, except we measure the gradient in the descending aorta. And this will also make us decide that this patient needs surgery or not, or needs something to be done or not. Not everybody has to have something happen. There's different grades of these diseases. It can be mild, can be moderate, can be severe, And that's where our imaging really helps to monitor and decide the timing or decide of these accurate measurements. We can decide the grade of increase. We know exactly if find that aortic stenosis today, that if their gradient or their aortic valve area is like 1.6, we see what we can expect the next year will be 0.2 centimeters square less. That's the maximum, but usually increases in 1 year. So we can follow this patient and know exactly that they are following the curve, what we know about, or they are outliers, which also happens. And then finally, here's the picture of the Gigiflux. This is the medication digitalis or digoxin made of. And this is one of the most ancient cardiac medications we have, made from these beautiful flowers. So I take any questions if you have, but this was really mainly show and tell for everyone, so you can actually visualize all these diseases and know what to expect from any kind of imaging you have.
We'll hold the questions for its break time.
Okay.